Okay, so DOACs, they have revolutionised, of course, our practice, but we can't use them in all circumstances. So I thought I'd cover some areas where there may be problems, and I'd be interested perhaps for a bit of feedback of what people do in their practice. But we know that patients are poorly compliant, and there might be an issue. There's issues with pregnancy, mechanical heart valves. What about venous thrombosis at unusual sites, such as CVST and abdominal vein thrombosis? Use in patients with cancer, where the gold standard has been low molecular weight heparin. Patients with liver disease, patients on interacting drugs, patients with end-stage renal failure, perhaps small bowel syndrome, and extremes of body weight. And I'll try and touch on those and tell you what I do in my practice and what it's based on. So I think the first thing to say is we all know this, but we keep forgetting it. So patients are terrible at taking tablets. The first study there is a study of patients who had acute coronary syndrome, and they were all supposed to be taking aspirin, a beta blocker, and a statin. And at 1 year, when they were all supposed to be on all three drugs, 71% were taking the aspirins, 46% the beta blocker, 44% a statin, and only 21% were taking all three drugs they were supposed to be taking. And then there's back to anticoagulation, there's an interesting study on warfarin, where patients' warfarin was in a little container with a chip in the cap, which the patients didn't know about. And of the patients who said they took their tablet every single day, their bottle wasn't opened on 21% of days. So that's with warfarin, which is quite forgiving. And of course, with the DOACs, they're short half-lives. I mean, I won't go through these graphs, but I think we can all appreciate that they have very short half-lives and wear off very quickly. And that actually like to be a real problem if patients are poorly compliant, particularly if you're on a drug that you take with a 12-hour half-life, you take every 24 hours. When missing a single drug, will bring your anticoagulation right down, because after 48 hours, I mean, obviously we could do major surgery, so you're completely unanticoagulated having missed a single dose. Pregnancy, we heard yesterday about the use of low molecular weight heparin, and there really don't seem to be any other options. It remains unknown if the DOACs are tetragenic, but they're small molecules, they're very likely to cross the placenta, and so they could impact fetal development and anticoagulate the fetus. The only study I know of is this one by Bayer-Westendorf, who identified 233 pregnancies, of which he could only look at the outcomes in 137, and 7 showed abnormalities. That was 5%, and it was judged that 3 of those abnormalities, or 2%, could potentially be interpreted as embryopathy. It's difficult to know what that means, but I think we'd all probably agree that at the moment we can't really use these drugs in pregnancy. Mechanical heart valves, the bane of our lives, really. We've got our big warfarin clinics. We're getting rid of all the VTE patients. We're getting rid of all the AF patients, but we're going to be left with thousands of patients who have mechanical heart valves. So where we've got to, I mean, this was some time ago, wasn't it? The Realign study published in, that you can see there, 2013 in the New England Journal of Medicine, where dabigatran was compared with warfarin for patients with mechanical heart valves. And of course, dabigatran against warfarin has been very successful in VTE and stroke prevention and atrial fibrillation. But here's the data from the mechanical heart valves. Patients were randomly assigned to dabigatran or dabigatran or warfarin. And you can see the dabigatran dose is interesting. Patients either got 150 milligrams BD, what we call the standard high normal dose, 220 milligrams BD, or 300 milligrams BD, twice the normal dose. And they all had levels done to make sure nobody had a trough level less than 50 micrograms per litre. But the study had to be terminated after 252 patients, and you can see why. In terms of ischemia or unspecified stroke, there were none in the 84 patients on warfarin at that point, but there were 9 in the 168 patients on dabigatran. 5% had a stroke. And perhaps not surprisingly, although dabigatran at the standard dose doesn't cause any more major bleeding than warfarin, at these patients who are having higher doses, there was a little bit of an increase in major bleeding as well. And they're the plots for those of you who like the plot. So on the left-hand side, warfarin's the top line, whereas dabigatran is under it, and again, it's the same for the bleeding data. So that was a failure, and obviously since then we've been I think we've been worried that none of the new oral anticoagulants would effectively let us use them in patients with mechanical heart valves. Came across this data, I have to say last year though, so it's a recent publication in 2017, because I think we have to probably go back to animal studies. So this was a study looking at apixaban versus warfarin for mechanical heart valves, but it was done in pigs with aortic mechanical heart valves. You can imagine how expensive these studies are. So these are 16 pigs who all had heart surgery to put in a mechanical aortic valve, and then were given 4 different anticoagulation regimes. So with only 4 pigs in each group, 4 of them had no anticoagulation. They didn't do very well. 4 of them had oral apixaban, 4 warfarin, and then 4 IV apixaban. But the IV regime was meant to sort of simulate the sort of levels you might get in humans. The pictures there are just from the first 3 groups, but you can see the valve, a typical picture of a valve there full of thrombosis with no anticoagulation, and the 2 valves which look a lot better on warfarin or apixaban, and the clot weight after 30 days when the pigs were sacrificed is there. So there may be some suggestion there that apixaban might work in patients with mechanical heart valves, but I think we're a long, long way off human studies. But it would be obviously a great breakthrough if we find that the 10A inhibitors can be used in this situation as opposed to the thrombin inhibitors. What about VTE to unusual sites? Of course, the trials were entirely for proximal deep vein thrombosis and pulmonary embolism. There are no trials in cerebral venous sinus thrombosis, abdominal vein thrombosis, which in my practice are the 2 biggest problematic areas for VTE at unusual sites. Of course, there's no data really either for upper limb DVT or calf vein DVT. I think we'd all extrapolate reasonably happily to treating upper limb DVT with DOACs, and I think those people who treat calf vein DVT have happily extrapolated to treating calf vein DVT with DOACs, which seems entirely reasonable. For superficial vein thrombosis, we do have some data. You'll be aware of the SURPRISE trial by Westendorf again, who did a randomized control trial comparing rivaroxaban with fondaparinux having been shown to be an effective treatment, and rivaroxaban was non-inferior to fondaparinux. So, and I think from memory that was the 10 milligram, so the prophylactic dose of rivaroxaban for 6 weeks was effective against superficial vein thrombosis. So I don't know what people tend to teach superficial vein thrombosis is. For many years, we've given them a 6-week course of intermediate dose low molecular weight heparin, but we're now moving to using prophylactic doses of apixaban or rivaroxaban for 6 weeks, and there is some data to support that. This is very recently, so this is this month, published from the Mayo Clinic, where they looked at some of their patients who had thrombosis in what they call atypical location. That's what the AL stands for. And they identified 63 patients with the various mixture of CVST, abdominal vein thrombosis, and a couple of other odds and ends, 36 of whom were on a DOAC, 23 on low molecular weight heparin, and 4 on warfarin. And they compared them with each other, and they compared them with patients who had what they call VTE at typical sites, in other words, proximal DVT or pulmonary embolism. And you can look at the paper yourself, the references there, but their overall interpretation was DOACs in this very small number of patients seemed to be as good as the other anticoagulants in patients with venous thrombosis at atypical sites, such as CVST and abdominal vein thrombosis, but with, as I say, obviously pretty small numbers. What about DOACs and cancer? So everybody knows the cancer story, I'm sure, going way back to Agnes Lee's clot study, where low molecular weight heparin was shown to be better than warfarin for patients with proximal vein thrombosis or acute pulmonary embolism who had an underlying cancer. And of course, all the trials of the DOACs for proximal DVT and P have been comparing DOACs with warfarin. So until very recently, we had no direct comparison of DOACs with low molecular weight heparin. But nevertheless, because low molecular weight heparin was the gold standard, when the trials were done, there were actually very few patients relatively with cancer entered because most people weren't treating them with warfarin to feel free to randomise them. Most people were treating them with low molecular weight heparin. But about 5% of the patients in all the studies overall, and the VT studies overall, did have underlying cancer. So the total numbers weren't too bad, especially if you start to do meta-analyses like these, which were done. This was done in 2014. So this is looking at the DOAC trials in the subgroup of patients with cancer, and you can see the recurrence rate at the top, and you can see the major bleeding and clinically relevant non-major bleeding at the bottom. So I think we can say from this that they're at least as good as warfarin, which of course isn't the comparison we necessarily want, but there is a hint that they marginally may be better than warfarin looking at the top graph, but that little diamond just pips the line of, meaning it's not statistically significant. Here's another meta-analysis done the next year, but if you look at the top graph first, you see there's two halves to it. The bottom half, in terms of recurrence of thrombosis, is what I've just showed you from the previous one. It's another meta-analysis, but it gives exactly the same result, really. So this one is DOACs versus, sorry, the top one there is, where am I? The bottom one here, sorry, I'm right first time. This is DOACs versus warfarin. In fact, what I've just showed you, showing the DOACs seem to be perhaps a bit better than warfarin, but it just crosses that line. But they've put the graph above it as a comparison, the analysis of low molecular heparin versus warfarin, where we know low molecular heparin is better, and you can see that clearly. But there doesn't look a huge difference, does there, between those two graphs in the top half of the slide? And then major bleeding is at the bottom, which looks satisfactory. So perhaps a hint there that these drugs would be okay in cancer, but I don't think the top graph really answers the question, are they as good as low molecular heparin or not? But recently we've had published online in the New England Journal of Medicine this study looking at edoxaban for the treatment of cancer-associated venous thromboembolism. So patients were randomized to edoxaban or the low molecular heparin dolteparin. So you get over 1,000 patients, over 500 in each group, and you can see the results there. So the recurrence rate was actually lower in the patients taking edoxaban compared to the gold standard low molecular heparin, which we know is better than warfarin. So about an 8% recurrence rate in the edoxaban group, and about an 11% recurrence rate in the low molecular heparin group. But that was at the cost of a little bit more major bleeding in the patients on edoxaban, so 7% versus 4%. So in this trial of edoxaban versus low molecular heparin in patients with cancer, as effective, maybe more effective, but in the dose used, but that dose had a slight increase in major bleeding. And there are the Kaplan-Meier plots of that. So the top is recurrent thrombosis. Edoxaban is the lower blue line, having less recurrences. But in the graph below, which is the major bleeding, edoxaban's blue is the top line, which is an increase in major bleeding. The SELECT-D trial, which was comparing rivaroxaban with low molecular heparin, was presented by Annie Young at ASH, and this and the next two slides are just her slides and a summary of her results. So this is recurrence rates, and remarkably similar, really. So in this graph, dolteparin is the top line, rivaroxaban is the yellow line, and you can see the recurrence rate, 6-month recurrence rate, is 11% on dolteparin and 4% on rivaroxaban. So again, very, very encouraging. Rivaroxaban not only as good as, but looking to be better than low molecular heparin in terms of recurrence. But at what cost? Well, very similar to the edoxaban results, which have been published in full. Total bleeding, 17% versus 6%, and major bleeding, which is probably what we're more worried about, 5% on rivaroxaban compared to 3% on dolteparin. So there's two studies there, which I think in conjunction with the systematic reviews I showed you earlier, I think should give us quite a lot of confidence that these drugs are effective in patients with cancer, and I think they probably are going to show, once all the data's put together, that they're as effective at least as low molecular heparin. There may be an increased risk of bleeding. I think most of the increase seems to be GI if you look through the data that's available so far. What about patients with liver impairment or cirrhosis, liver impairment? Well, the SPCs are remarkably similar in their phrasing. A couple of them are quite different, but they tend to use this key phrase. They say these drugs are contraindicated in hepatic disease, and then the quotes, associated with coagulopathy and clinical relevant bleeding risk. So I think we could all probably identify liver disease patients who have coagulopathy, which aren't huge numbers actually, overt, I mean. But clinically relevant bleeding risk, well, obviously they all have a risk of bleeding. So when does it become clinically relevant? So again, not a lot of data, but this was a recent publication from last year in 2017, which looked at 27 patients with cirrhosis. So again, all these niche areas, we're talking about very small numbers. And in this study, can't remember. No, it was 27 patients were prescribed a DOAC, sorry, and then there were 18 patients on standard, what they call standard anticoagulation, the vast majority of which 15 were on warfarin. So this compared 27 patients on a DOAC versus 18 patients on standard treatment, of which 15 were warfarin and 3 were low molecular weight heparin. And you can see the major bleeding rates, and I don't think this comes to any surprise to anybody who's given warfarin to patients with liver disease. 28% major bleeding rate for the patients on standard anticoagulation, nearly all of which was warfarin. And I think everybody will accept how difficult it is and won't be particularly surprised by that. But rather gratifying that major bleeding only occurred in one of the 27 patients given a DOAC, which is hugely better than at least them on warfarin. And that wasn't at the cost of any increased recurrence or stroke. There were a mixture of AF and VTE patients. You can see 4% versus 6%. So very similar. Now, we give these drugs in fixed dose with no monitoring, and that's great. But there is some controversy about that. Do we need to worry about what plasma levels you get, or do they work in some magic way where it doesn't matter what your levels in the plasma are, but they work anyway? Seems unlikely. And I don't know how many of you remember this, or the hatchet job. The BMJ's turned into the Daily Mail or the Daily Mirror, I think. You remember this headline? I don't know if you remember this cover of the BMJ with blood dripping all over it, saying dabigatran, the analysis the regulators didn't see. And the reason for this is, well, to be fair to Boehringer Ingelheim, the BMJ accusing them of not publishing, hiding data and not publishing it, it was in full view published in JACC. So this is data that was published by Boehringer Ingelheim. And it shows along the bottom there is the trough concentration of dabigatran, and on the y-axis is the endpoint. So pink is your risk of major bleeding going up as your trough level of dabigatran goes up, not surprising, and the blue is your risk of stroke coming down as your trough level of dabigatran goes up. So yes, plasma levels do matter. If you have low levels, you're more likely to have thrombosis. If you have high levels, you're more likely to bleed. That's not surprising. But to be fair, there is quite a wide therapeutic window which enables us to give them in fixed dose. What the BMJ was accusing Boehringer Ingelheim of is they did an analysis of this data saying, well, we don't really want to measure them, but what would happen if we did? And their analysis said, well, if we measured them, and in patients who had high levels, we dropped them down a dose, we could not really have any more strokes, but we could actually reduce some major bleeding. So by measuring these drugs, you probably could make them even safer, but at a lot of aggro and hassle. But this doesn't just apply to dabigatran. I mean, the other companies haven't really, other than the data for edoxaban, I haven't seen any for rivaroxaban or apixaban. But this is the data for edoxaban, and again, it's pretty much what we would expect. The pink is your risk of bleeding going up as your edoxaban levels increase, and the blue is the risk of your stroke going down as your edoxaban levels increase. So plasma levels will make a difference on a population basis. So what about things that might alter your plasma levels, and do we have to worry about it? So the first one I'll just touch on is drug interactions. I won't read the whole list out. I don't know if you can see it. It's quite small print, but you'll know the drug interactions from the SPC. And interestingly, they tend to put them in two categories in the SPCs. So they've got avoid and they've got caution for dabigatran there. Rivaroxaban actually says avoid. It doesn't give any cautions. It just says avoid those drugs. Apixaban says avoid, and it has a caution as well. And edoxaban has no data on those, caution, and reduce the dose with the other ones. But you can see all the drugs are very similar. And I've put in red the ones we have most problem with, and the fact that really carbamazepine and phenytoin, but we seem to have quite a few number of patients coming to the DVT clinic who are taking carbamazepine. And those drugs in red there will reduce plasma levels of the DOACs and the drugs where it's highlighted there. And we don't use them in acute VTE in patients on those drugs. And I think that's what the SPCs would suggest, and I think that's what you should do. You will probably get significant reduced levels if you're taking those drugs. The ones highlighted in red are the common ones. Of course, HIV protease inhibitors have the same problem, but very much fewer patients are on them. The other drugs that are repetitive in this list are the azole antifungals, which of course have the opposite effect. They tend to increase plasma levels. And you can see that you've got ketoconazole, itraconazole, and the rest. But interestingly, fluconazole isn't on there. So I was interested when I came across this very recently. So this was a study from Taiwan, where they looked at a massive number of patients, over 90,000 patients with AF on DOACs. And they have a national database where they could look at all the drugs all the patients are on and look for any interactions. So they looked at patients on fluconazole, which we've always thought is absolutely fine. And they looked at, was there any increased risk of bleeding if patients on DOACs were taking concomitant fluconazole? And you can see the relative risk of bleeding with the 3 drugs they looked at. So 2 to 3 times the risk of bleeding in patients on dabigatran, rivaroxaban and apixaban who happen to be taking fluconazole, which is of course much more common in clinical practice. So we had to think, well, does that really mean anything? And of course I think the first point is patients weren't randomized to fluconazole. This was just a study, so a cohort study really. So are patients who take fluconazole likely to be different from those who don't take fluconazole? I mean, I think definitely. I mean, presumably they're taking fluconazole for a reason. Now, all the DOACs shown there are substrates for P-glycoprotein, and both rivaroxaban and apixaban are metabolized by cytochrome P450 system. But fluconazole's always been separate from the other azoles, as it is in all the SPCs, because it's only a moderate inhibitor of CYP3A4. Whereas ketoconazole, for example, is a potent inhibitor of both that and of P-glycoprotein. So you wouldn't really expect fluconazole to have the same interactions. For the moment, I would take that with a little bit of pinch of salt. We've not altered our practice, and I think fluconazole can be prescribed with DOACs, but it might be prudent to be cautious if patients are on a high dose of fluconazole or they've got renal impairment or there's some other risk factors for bleeding. But at the moment, I don't think I would not use, I think I would use them in patients on fluconazole. What about renal function? Well, I think we all know what the SPCs say, so I've just highlighted a couple of things there. So for dabigatran, you can't use it if the creatinine clearance is less than 30. Now, despite virtually no data at all, for the other 3 drugs, you, according to the SPC, can use them down to a creatinine clearance of 15, although I have to say we don't use them for patients with a creatinine clearance below 30. But you can see what the SPC say about the dose you should give if patients have got impaired renal function. And for acute VTE, you shouldn't really be making a dose reduction. So for rivaroxaban, it says for DVT, recommend no dose reduction if the creatinine clearance is between 15 and 50. But then rather unhelpfully, it says you might consider it. For apixaban, it's very clear. It says no dose reduction for patients with a creatinine clearance of 15 to 30. In both cases, it says use with caution. So I'm not quite sure what that really means. But there is some data on these drugs with renal function. But unfortunately, all the data only really goes down to a creatinine clearance of 30. There's virtually no data for a creatinine clearance between 15 and 30. So the very left-hand part of this graph, and the next graph I'm going to show you, is a creatinine clearance of 30. And then you've got better creatinine clearances going to the right. There's 2 doses of dabigatran here, 110 and 150, top and bottom. But you just need to really compare left and right. Left is your risk of stroke, and right is your risk of major bleeding. So the black line is warfarin. So the first thing to say is patients on warfarin who've got renal impairment, or very mild renal impairment in this case, their degree of anticoagulation isn't altered. They're all getting warfarin with a target INR of 2 to 3. So all these patients have an INR of 2 to 3 and are similarly anticoagulated. So in terms of the level of anticoagulation, of course, renal impairment has no effect on patients on warfarin. But despite that, your risk of stroke goes up quite dramatically on warfarin as your creatinine clearance comes down. So that's not an effect of not being anticoagulated. That's an effect of you're more likely to have a stroke as your renal function gets worse. And interestingly, with dabigatran, the red line doesn't go up as much as you go to the left on the left-hand graphs there, which I think means because you're getting higher plasma levels as your renal function goes down, you're getting some extra protection, perhaps to the point where you might need it, you could argue. But there is a cost of major bleeding. Again, looking at the black line first, your risk of major bleeding it goes up as your renal function goes off, independent of your degree of anticoagulation. But if you're on dabigatran, you can see it goes up quicker, probably because you're accumulating drug. Now, here's very similar graphs for apixaban. So the left-hand side is stroke or systemic embolization. The right side is major bleeding. The blue line is warfarin. So again, I think it's sobering to look at the warfarin line more than anything else in these graphs. So these are patients with the same degree of anticoagulation, the risk of stroke going up dramatically as your renal function goes down, the risk of major bleeding going up dramatically as your renal function goes down on patients on warfarin. But the interesting thing is there is much less effect in patients on apixaban. So actually, if you compare relatively warfarin versus apixaban as your renal function goes off, apixaban starts to get bigger advantages as your renal impairment gets worse, down to 30 though, down to a creatinine clearance of 30. And here's a systematic review of all the trials looking at patients who had creatinine clearance above 80, creatinine clearance of 50 to 80 in the middle, and creatinine clearance of 30 to 50 at the bottom. This is stroke or systemic embolization, and you can see we can be really confident of using these drugs in patients with a creatinine clearance of 30 to 50. And in terms of major bleeding as well, in fact, if anything, better than warfarin. The warfarin effect, they're even better than patients with good renal function in terms of bleeding when you've got a creatinine clearance between 30 and 50. But again, no data between 15 and 30. So despite the fact that we've got virtually no data anywhere for patients with a creatinine clearance between 15 and 30, I was astonished by this FDA label for apixaban, which I'm sure many of you are aware of, because it actually gives the dose you should use in patients with end-stage renal disease maintained on dialysis. And it says if you're maintained on dialysis, you can have apixaban at 5 milligrams BD, or if you weigh less than 60 kilograms or over 80, perhaps you'd have 2.5 milligrams BD on patients of end-stage renal disease on dialysis. No data. I thought that's quite incredible, actually. But based on pharmacodynamic analysis, I think they say. What about patients with short bowel syndrome? So this raised its head with me a couple of years ago. There's a bowel transplant program in Oxford, and there's a big GI unit, and they have a fair number of patients with short bowel syndrome who tend to have significant problems with thrombosis. And so I've come across 2 or 3 patients where we had a discussion about whether they could have a DOAC or not, which mainly relates to absorption. And in the interest of time, I won't read through these slides, but effectively this is simply a cut and paste from notes I made myself, and I was trying to work out if it was worth trying something and what we should try. And to cut a long story short, when I looked at the data of how much of these drugs were absorbed where, high up in the stomach, high up in the small intestine or lower down, and I tried to decide which one we might try if we were going to do it, it looked like rivaroxaban might be the best one to go for. It's got a high oral bioavailability. And what does it say there? Absorption of rivaroxaban is dependent on the site of release. Absorption decreases distal to the stomach, with noted decreases as you go further down the small intestine. So that might be an issue for NG feeding, but actually might be good if you want to try and use it in people with a small bowel. So I did give 2 or 3 patients rivaroxaban, and we measured levels, and they seem to be okay, but that's very, very anecdotal. So I was pleased to see this study, which I think from Saskia Middledorp's group, who spoke yesterday. And it's only 6 patients, but they studied it in a very much more systematic manner. So there's 6 adult patients with a remaining small bowel length, less than 20 centimetres. And they gave them dabigatran, they gave them all dabigatran, measured levels. They gave them all rivaroxaban and measured levels, so a nice study. And you can see the mean peak dabigatran and rivaroxaban levels, the mean trough, and the 90% confidence limits of those peaks and troughs. And I think this is a very nice graph. So the top graph there is the data from dabigatran on patients who I think are taking it for 5 days and reach some sort of stable level. The horizontal lines, the normal peak and the trough you would expect in patients without small bowel on those drugs. And you can see for the 6 patients taking dabigatran, apart from one of them, they pretty much fell woefully short of it, actually. The rivaroxaban data, I think, is much more encouraging, as I might have expected. So you can see the peak and the trough, and it's not too bad, really. So it might be worth trying rivaroxaban in these patients as long as you measure levels. in them. And I'm going to finish by just talking about extremes of body weight, which is quite a contentious issue. You'll all know what the SSC say. In fact, the SSC is slightly schizophrenic, really, because it says, don't use these drugs in patients who weigh more than 120 kilograms or more than 40 milligram per meter squared BMI. Full stop. And then they say, if you do, measure the levels. And if they're okay, perhaps it's okay. And if they're not okay, don't try and mess about with it by increasing the dose, abandon things at that point. That's what they say. Have we got any data? Well, unfortunately, we have got very, very little data, if any, on patients more than 120 kilograms. We've got analyses like these, which are quite interesting and reassuring to some extent, which this one was a sub-analysis of Einstein, which compared people basically over 100 kilograms with those less than 100 kilograms. And you can see the recurrence rates on rivaroxaban was 1.9% in those below and 2.3% in those above, which isn't too frightening. And you can see the figures with warfarin were 2.4% and 2% on those who were heavier. And major bleeding, it was the same in patients less than 100 kilograms or more than 100 kilograms on rivaroxaban. So sort of reassuring, but that's over 100 kilograms. And nearly all those patients were between 100 and 120 kilograms. Again, another review looking at below 100 versus above 100, a systematic review now, including that study and all the other studies. So the top is recurrence, I think, and the bottom major bleeding. But you can see virtually no difference in patients below 100 kilograms or more than 100 kilograms, but with a caveat that all the patients above 100 kilograms, virtually all of them were between 100 and 120. Rupin, this comes from your group recently, I think. This was 101 patients prescribed rivaroxaban prophylactically or in treatment doses for the prevention or treatment of VTE. And they did a quite a nice, neat population pharmacokinetic analysis which suggested that the most important factor predicting plasma levels was the creatinine clearance. And in their model, weight seemed to have little effect. But again, although there were 17 patients above 100 kilograms, I don't know if you know, Rupin, it doesn't say the number above 120, but only 6 were above 101 kilograms. So I don't think we have much data to go on in that group over 120. So in summary, where does all that lead us? He's going back to the beginning. In my practice, I'm reluctant to use these drugs in patients who I think are going to be very poorly compliant. I don't use them at all in pregnancy. I don't use them at all in patients with mechanical heart valves. I do think it's reasonable to use them, and I do use them in patients with cerebral venous sinus thrombosis and abdominal vein thrombosis. In those with CVST, I tend to treat them with low molecular weight heparin for the first 1 or 2 weeks, which also means because I'm using apixaban at the moment that I don't have to give the 10 milligram BD dose. I can go straight to the 5 milligram BD dose when I switch. I think it's reasonable to use them in patients with liver disease without coagulopathy, and I think it's almost certainly safer than warfarin. I don't use them if there are likely to be significant drug interactions, and I say the commonest thing in our clinic is patients on carbamazepine and perhaps phenytoin. We don't use them with below a creatinine clearance of 30 at the moment, and I certainly wouldn't use them below a creatinine clearance of 15. I think for short bowel syndrome, you might want to try them, particularly perhaps rivaroxaban, as long as you measure levels. And the most contentious one of all, I think, we don't use them in patients with a body weight greater than 120 kilograms. And there I'll stop and be interested to know what other people do. Thank you.